It will be a very small group, but with family atmosphere. I'm really glad you choose this session and what is very special to all of us. And at the same time, we are living in a really fascinating time because we were just reflecting the fact that, that just 10 years ago, we didn't know how many universities are operating specialized addiction programs, and we just know about each other in terms of couple of core group. And I'm really glad to have colleagues from Virginia Commonwealth, so it was one of the first program. And we have also some traditional programs in Europe, but some of our speaker, it will be first speaker, and maybe I will use it as a bridge. Amalie conducted a survey, big online survey, with universities and websites of universities around the world and mapped these programs. She started in Europe and continue on in America, Northern America, Africa, and now we have under review New Zealand and Australia region. And so she will speak about something a little bit different, because from mapping we moved, and in 2016 we established ICUDDR, and since this time this family growing constantly and exponentially. At this moment we have almost 450 member universities, so that's a huge group, and many of these universities have specialized programs. And now we have a first output from a bigger survey what we did and what we conducted and analyzed this data, and I think that it can provide very interesting picture, much better picture and bigger about what is happening in this segment. And I think that it will be the perfect introduction into our today's session, and then we will continue on with other speakers because we have many other interesting issues, and I will introduce other colleagues after all. So, Amalie, microphone is yours.
Okay, great to see you, ladies and gentlemen. Good afternoon. My name is Amalie. I will not introduce myself more, as what was said already. I'm representing Charles University in Prague here, but it's my huge pleasure also to represent the partner of ICUDDR, as already has been mentioned by Michal. This is our together work, so I'm the presenter, but I'm definitely not the one who made the survey and who created the data which I will be presenting to you. Other colleagues are not sitting here, but we have Michal also here, and the others are anywhere in the conference, so you can then ask if you have more specific questions to them. At this point, I just want to make a short disclosure. What I want to really mention loudly is the special thanks to our colleagues who cannot be here, Anna and Andrei, who were really interested and really included in the survey, in data analysis, questionnaire preparation, and all the implementation. And I would like to special thank to you, if you are here, who are participated in the survey, who are the active members of ICUDDR and helping us gathering these data, because without the members who are active and available to respond, this wouldn't be possible to be presented. It's just a few here sitting, but you can definitely make pictures of those figures I will present, but I would like to kindly ask you not to publish it anywhere or reproduce it without our permission, as the data are now undergoing the review for being published, and hopefully you will have all the data at one place soon, so we will then be able to share the PDF for you if you would be interested. Thank you for that. I would like to start with just emphasizing the importance of the topic of evaluation, or why such surveys are important to be conducted. And ICUDDR is making great work in regularly mapping the members and trying to find out what are the needs, how the programs are developed around the world, how they are dealing with all the challenges in the countries and in the regions, because it's really different in the part of the world. And this is the key feedback we get from our members to make the priorities, to make it easier to distribute the curricula, to help the members develop new programs and so on. So this is the #1 feedback we need to get, and we will continue in this work continuously, of course. Really shortly about the methods. It is possibly you can guess what we did, but it was a method of online survey. We used a questionnaire for gathering the data, and the response rate was 25% of the ICUDDR members. I will show you more later about the structure of them. Just to be clear, because there are, and also in the questionnaire, there were 3 categories, 3 educational options. We structured like that. Hopefully it will be understandable to you, but if not, please give me a feedback at the end. It could really help to improve our next surveys. So the first level we differentiate is the degree level. We define this as the program which enables the graduates to gain a degree, a qualification or a specialization in addictions, mostly the typical degrees like bachelor, master's, PhD, or the more specific graduate and postgraduate diplomas and certificates, or other options as associate degrees, for example. The second category is represented by the academic courses, which is meant for the specific courses focused on addiction topics, but not for gaining the specialization per se, just for broadening the knowledge of mostly students of other disciplines, like medical doctors, nurses, psychologists, social workers, others who are interested and who are in contact with substance users. The last category is represented by the lifelong learning educational options. These could include all trainings, all courses following the previous degrees, following the previous education the professionals have. Now I'm jumping into the results. You can see the figures in colors. This is the structure of the members, of the participants in the survey. You can see how regionally the participants are structured. There are actually mostly people or universities from Asia and Pacific region, from Europe, and also from Africa. But if you see in the brackets, there are numbers, like the percentages of those out of all members of that region. And then the number is quite different. And we can see that Europe is definitely the #1 in responding to the survey, following by the Middle East. And you see USA and Canada, and also, as it was mentioned before, New Zealand, Australia, they are really underrepresented in the members also, but in the survey. And I think this is really important gap we need to fill somehow in the future. Here you can see the structure of the degrees. That's the option 1 I presented before. You can see that in total 35 universities stated that they have at least 1 degree programs specifically for addictions. And the degrees are divided in the colors, but what can be sum up is that the graduate level is absolutely the most represented part of education in addictions. These are represented mostly by master's programs or graduate or postgraduate certificates and diplomas. It depends on the region where it is provided. If it's graduate or postgraduate, the terminology is quite tricky sometimes. You can see also the PhD programs, and it's not so bad, I guess, around the regions. That is quite new data. In the previous studies, we had really like underestimation of PhD programs, so it's mostly on the upper level of education. The academic courses, as I mentioned before, are mostly meant to medical students, to students of psychology, social work, nursing, pedagogy. You can see the other disciplines who are included. These are not awarded with a specific degree, as I previously mentioned. What I want to emphasize here is the attention to the topics which are included in the courses. You can see, and I will show you more about the concrete or the specific topics taught in the courses and in the addiction studies. But here I can mention that for the academic courses, harm reduction, criminal justice and law, and public health and aftercare are the topics which are underrepresented, but in a huge scale. I think this could be a warning for all of you who are educating students and future professionals in addictions, as I think this is really necessary to be raised and make it sufficient for the curricula. Here, promised topics. These are the top topics. You can see what topics are mostly included or represented in the educational options for academic courses and also for lifelong learning of addiction specialists and also other disciplines, other professionals working in addictions. You can see that it's quite repetitive. There are treatment, mostly prevention, alcohol, diagnostics, assessment, some key methods, counseling, treatment, interventions. But again, I need to say that at the very, very bottom, there is the topic of harm reduction and criminal justice and law. For the lifelong learning programs, there's just information shortly that 40 universities out of 99 who participated stated that they provide some lifelong learning programs. And again, the same professionals working in the field. These are the related professionals, related disciplines who need to be in collaboration with addiction specialists, so it is not surprising, I guess. What was interesting was the number of addiction programs under development, which universities informed us about being prepared. If you are sitting here and we don't know about you yet, please tell us if you opened your new program. We are really interested in that. I will ask Kevin and Carly if they have some more information about it. This could be quite of interest again. It's about UPC and UTC implementation into the addiction studies, no matter what educational option we mean, because there are quite huge differences between the categories. I can say that the higher the level of education is, the higher is the probability of UPC and UTC being included or implemented within the curricula. You can see that UPC is mostly represented in degree programs, while UTC mostly in lifelong learning programs. And this is quite interesting, as maybe it could be more divided regionally, and we can go deeper in the data still to see how is that possible, that there are such differences in the implementation. These are the tools. Who you don't know, you can use all of these provided by ICUDDR and also ISAP. And in bold, you can see the most used, most represented tools which members are using, provided by ICUDDR. And at the bottom are the, not so well used. What I want to mention are the online tutorials. I think this could be like quite great option to take and to use for education and for broadening the scope of our addiction studies. And also academic mobility is not so used. Again, the question, why is that possible? How is it influenced? If it's regionally influenced, or if it's the issue of finances, I don't know. But these are the tools the ICUDDR could definitely support more in the future. And I would like to finish my presentation by raising some challenges we faced during the survey. I think, again, not surprisingly for you, the most issue is the language. The questionnaire was prepared in English, and we are repeatedly talking about preparation of the questionnaire in Spanish also. On Monday and Tuesday, I saw how many people are here Spanish speaking, so I'm a bit sorry to all of you who are Spanish. We will definitely make it better in the future. And also, it's not just Spanish. English can be a really limitation for the participation, and if it's the only option, I understand that the universities are not responding to the survey. We have, as it has been mentioned, we have now over 450 members in ICUDDR. It's over 60 more than in 2023 when the survey was conducted, and only 25% response rate. Still, we can ask if it's just the language or if there is anything else happening behind what we don't know. If you have any ideas, I would really appreciate to hear that. Another issue can be that the questionnaire was quite in detail, and there was a lot of questions. I realized then when you are not the head of the addiction study program, then as a teacher, it's possibly not easy to fill the questionnaire as a whole. So this could be another limitation we face too. And the benefits, that's what I would like to end with, because these are the strengths of our survey, and I think they are important, is that such surveys, except for the feedback for us, are definitely serving as something what can contribute to our knowledge, to development of what's happening around the world. We can collaborate mutually, we can be mobile, we can make some exchanges of teachers, of students, we can make joint degrees, we can, we can really stand on the data. So that's why is that so important. And my last note here is that for the future, and for Elizabeth, who will be speaking after my presentation later, and she will tell you more, there is an important issue of quality standards in education, I mean the university education especially, and preparation of the core competencies, really the core competencies of the addiction specialists after graduation in degree programs, and the bodies who should be included in this process. So these are the milestones we need to have for building the future steps, and I hope we can make it better for the next wave. Thank you.
Thanks so much, Amalie, Dr. Lososová. And because we have a very homogeneous session, we will have a general discussion at the end after all of presentations. So let me introduce you with Maria and Marcela very briefly, because both ladies are coordinating, preparing, and running diploma in substance use of Catholic University in Uruguay. Dr. Maria Fernandez holding 2 PhD two PhDs, and one of them is from University of Ghent in Belgium, and by the way, she has also master degree in psychoanalytic studies at the University of Sussex. Dr. Marcela Carbachó, is it? Okay, thank you, sorry. She holds PhD from Catholic University of Chile, and she's also associated professor at the neuroscience, and at the same time, she is focused on research of protected factors and studies of emotions and social cognitions and executive functions. So both ladies are highly trained and perfectly prepared for something like running a program like that, and I will be really happy to hear more about this new program in Uruguay. Thank you. And please, microphone is yours if you will need help.
Well, good afternoon. We are very pleased to be here. Thank you for ICUDDR. And first, yes, we will start presenting briefly the context of drugs in Uruguay. Like many other countries, we've been facing new challenges with increasing drug consumption, the synthetic drugs. In the region of Latin America, together with Chile, we are the countries with the highest prevalence in alcohol and marijuana use, which are the main substances consumed there. As well, coca paste has been increasing a problem because of the impact, especially with vulnerable people and in regions with poverty. And so in this context, also we've been having in the last years changes in political policy and legislation in relation to tobacco and marijuana. And the last 2 years, the government set up a strategic line of intervention with focus on mental health and drug issues. And the budget was allocated for that. So in that context, as well, we assessed there was insufficient of a specific training about substance use disorders. And so in that context, we started planning the development of a diploma through the university to tackle these issues.
So in this scenario, we decided to develop a diploma to provide specialized training for professionals and technicians who were working in the front lines, and also for future workers in the field. So our purpose with the diploma was to provide foundational knowledge and practical skills, also focus on evidence-based prevention, intervention, and treatment, ensure accessibility with affordable cost, and also addressing the problem of knowledge centralization. We have in the capital, we have a big problem with that in Uruguay. Of course, addressing the complexity and multi-causality of the problem, and promote community involvement. To the development of the program, we follow guidelines from ICUDDR that included the assessment of local training needs, collaborate with rehabilitation centers and drug policy experts, review existing academic programs, both local and international, consult with international agencies, engage with the National Drug Board in Uruguay, and connect with drug professionals and researchers in our country.
We also include in the program, we had meetings, and we include the UPC and UTC training from Colombo Plan. And we also include the knowledge we had from our research lines at the university. And we also try to adapt the global perspectives to our local context and our local needs through the program. And we were encourage as well our students to register with ISUP and to take all the additional training courses that they have available at the platform. So with this joint efforts and all this collaboration from the different agencies, we develop an 8-month curriculum, a diploma. Here you have all the main topics covered. And we use an active learning strategy. The diploma has a total of 130 hours. It's online with free in-person sessions. We have also visit to treatment center. And so we use a learning, project-based learning methodology that we thought that was in order to facilitate the students with the reflection on their application for their work context.
A critical aspect of the program was evaluation of the continuous learning and the applicability and transfer of the knowledge. For this purpose, we designed an assessment model that was based on the item model from Nielsen and Shepard. It's a model developed to assess mental health training programs. We adapted this model to our purpose, and we defined 3 times for assessment, one at the midterm, another post-training, and a 6-month follow-up. We began on April 2024, so now we are in the midterm. We are started the assessment process. In this period, we evaluate work context of the participants of the diploma and also motivation variables like intrinsic value, self-efficacy, academic satisfaction. Then we will evaluate on the post-training, and we hope we can evaluate 6 months after the end of the training with focus group to assess the students' experiences applying the knowledge from the diploma. So, as I said before, we launched on 2024. We had a great response in Uruguay of the community. We early fulfilled the spaces, the places, and we also have a wait list for the next edition, so we are very happy with that. In this edition, we have 40 students from capital and countryside. Most of them are from the countryside, and they have a very diverse academic background and work experience, as you can see there.
So we are already thinking in future plans and new challenges. So we are trying to implement for the following year, create a clinical unit at the university, so where students and graduates from the diploma can have a brief practical interventions, so they can do screening, assessment, and referral in relation to drug issues. As well, we want to, it's very important for us, the continuous evaluation of the program to improve the diploma, but also to try to assess the real impact of the knowledge they acquire in their work context. So the transferability, and this is a more complicated assessment, and we need a bit of help with that, but we are planning to be able to do it soon. So thank you very much again for all of the agencies and all of the people that were involved in helping us and supporting us in the development of the diploma. Thank you.
Thank you very much, and it's great to see that We have a new program in Uruguay, and that's wonderful. So my duty is to invite the next speaker, who is Elizabeth Novak, and she's from my team, and she's doctoral student on Department of Addictology on Prague, on Charles University, and we always are talking about evidence-based and how to translate research to praxis, and at the same time there are not so many people who are really interested in such a things, and that's always very tricky to find somebody who is really interested in quality and quality standards and quality assurance system, and Elizabeth is one of the very few person in, not only in our team, but generally, because I see that there are not so many colleagues who are really interested in these issues, and she's one of them, and she has some first very promising result, and I'm really happy to give you a microphone and ask you for your presentation, Elizabeth.
Thank you, Professor Mijovský. My presentation today will be about education in addictions, and mainly with a focus on quality assurance and evidence-based approach. This is the same disclosure. I will be talking also about the WAVE project activities, and these are our colleagues who are not here, but we want to mention them as well. And the same like Amalie said. So, in the beginning of the WAVE project, we wanted to create comprehensive reviews on competencies in addiction professionals and related professions. The objective was to map the situation, prepare an overview of existing quality assurance tools in education and training, make all those colorful, beautiful tables, compare them, check the discrepancies. However, soon enough we realized that the task is more than challenging. Addiction field is based on multidisciplinarity and cooperation of professionals who, of course, have different needs, different education background, different skills and abilities. And related to competencies, we need to distinguish between competencies for professionals that are necessary for a particular job position and educational competencies that prepare the student or trainee for the performance in practice. During the research, we were able to see that education and trainings vary a lot regionally, and that we are lacking of uniform perspective and universal standards and competencies. The papers reflected huge differences in terms of competencies, curricula, standards, yet experts were clear about the need to establish core competencies for addiction field and for some kind of the standardization in our field. I am going to focus on WAVE project activities. The task for our team was to create a series of reviews or systematic reviews on competencies in addictions generally and for related professions, namely psychologists, social workers, medical doctors, nurses, and most of them are being finished or under the review process. But I'm going to share some interesting findings with you, so you are lucky guys. Before that, I would like to shortly mention why quality assurance is such an important topic. I'm sure we all know that, but just to remember, for effective health systems, and not only health systems, we need a resilient, skilled and competent workforce that can provide services on a high level, accessible, achievable and acceptable to those who are in need. Education must be developed hand in hand with practice to reflect its needs and to react on a changing world. One of the tools in quality assurance are quality standards. They are the bridge between science and practice. They set the minimum level of good quality and safe, effective care, and they are also a tool for self-evaluation for a service or company. The fun fact about quality is that it does not have any universal definition, and probably all of us sitting here would describe it slightly different. So the most important thing, and maybe most important take-home message from my presentation, is that discussion is needed. We need to lead a mutual discussion about quality to unify our points of view, our objectives, and reach some kind of consensus when we are trying to improve the quality. Quality assurance is never-ending process of monitoring and improving quality through the multiple steps, starting with assessment, ending with the control of results, and starting the whole cycle again. Both workers and clients must be involved in quality improvement activities. And competencies help to uniform the knowledge, skills, and abilities, and they should be explicit, measurable, and transferable into practice. Oh my God, no. Yes. Okay. We know that competencies can be clustered, for instance, to core, advanced, among reach level, or on the basis of concrete provided intervention. Individual competencies can be then organized in competency models. Those models help to create a framework for effective performance in a particular position. These models mainly focus on what should learner or trainer do instead of know. Education based on competency models emphasize both academic knowledge, the ability to transfer it into practice, and engage in lifelong learning process. To be able of this, it seems like the competencies such as growth mindset, metacognition, self-regulation, advocacy, social emotional skills, and achievement orientation need to be developed. Even though the competencies in papers vary a lot, there are some that are frequently repeated. Early recognition of signs and symptoms, knowledge of the spectrum of mental health disorders, the ability to make a referral, and of course knowing the network of the services in the community, empathy, communication, and ethical practice, public education and awareness, linkages to community resources, and strengthening the community. And of course, providing interventions to clients and their families. It seems quite clear and easy if we check the list, but bearing in mind that competencies must be measurable and explicit, it seems a little bit vague and abstract. It's hard to measure something from this list. Professionals should come across as caring and compassionate, empathic, friendly, reliable, accepting, and understanding. Those are most mentioned characteristics in the papers we found. And what seems like really emerging and emphasized topic is culturally sensitive approach. This is my sophisticated art. That's how I imagine the competencies. So in the middle are skills, knowledge, and abilities. It's framed by personal characteristics, organizational characteristics, and cultural aspects. It seems like not only is the high quality education and training important for workers and their sense of efficacy, but it has a positive impact on clients themselves and on the retention in treatment. Also, students may be more engaged and motivated, and educators can apply their effort where students need the most support. Competency-based education is in contrast with the traditional job analysis approach, which divides position requirements into many specific elements. The competencies are supposed to serve as a foundation for professional development, and addiction studies could be established upon competency models that enable the required skills, knowledge, and practical competencies to be defined. So our research revealed discrepancies in many areas, including competencies, education styles, and standardization. Establishing an internationally applicable set of competencies is highly challenging, not only because of cultural differences, but because of diverse needs in diverse areas. Making them globally applicable and evidence-based, of course, make the process even more challenging. However, I don't want to lead us all to pessimism and depression in my presentation. So let's mention some of the amazing activities that have been done in terms of quality in education. And we can see that there is a lot. Of course, a great part of work has been done by ICUDDR and ISAP and their curriculums and tools. Also emerging international networks that support collaboration not only between universities is important, as well as extensive work of our colleagues in the US, and they work on curricula, advocacy, and competencies. Not forget to mention mapping the education and quality assurance in Europe, African countries, and the US, done by Amalie and her team. And actually, she was awarded for this work a few weeks ago. We need to continue on this not easy journey because for the implementation of competency-based education, there is a need of cooperation of universities, stakeholders, providers of care, implementing the tools to support professionals and build the capacity. There is a number of future challenges because of the changing world and dynamic development not only in our field. We have to face new facts, new topics and patterns, and respect the regional and cultural aspects even more. No matter all the difficulties, the need to establish educational standards and core competencies in addiction field is more than clear. So let's do it. I definitely overused the word challenging in my presentation, but I don't think it's a coincidence. I think it's really related to the topic. So thank you for being here, thank you for listening, and thank you to have a possibility to get such a great inspiration from you all.
Thank you very much, Elizabeth. And my duty is to invite our last speaker for our session, who is Anna Tsiboukli from Department of Pedagogy and Primary Education, National and Kapodistrian University of Athens. And at the same time, she's representing our Greek hosting partners. And at the same time, I should to add that Anna, I met her for first time 20 years ago on Hydra Island, and we were with Professor Richard Pace, just remembering how important meeting it was for ISAGE, International Society of Addiction Journal Editors, and in that time Anna was serving to Greek National Journal on Addictions, and she did it for many years restlessly, and invited Richard and other colleagues from ISAGE to serve and provide training for students on universities in Greek in publishing addiction science skills. So thanks so much, Anna, for your
Thank you very much, Mikhail.
enthusiasm and a lot of energy investing into our field, and microphone is yours.
Thank you very much. I'm really happy I'm here with you and Richard and Tom and Nick and other people from the past, and I hope from the future as well, that we are going to continue being together. I will try to give you just a perspective of what is happening in Greece in this field, and provided that I can change my, sorry. I think I have to use this mode. Right, just to give you a brief understanding, I think it's important to talk about perhaps cultural differences, or you might agree that you share the same circumstances in your countries, that the drugs field is definitely, as you said, multidisciplinary. Many people from various sectors work there, but we also have a big number of peer workers, people who had the lived experience, and they when they completed their treatment, they actually started to work in this field, at least in Greece. So we have to say that there is a discrepancy between what is the academic world and what is the treatment and the prevention world out there. At least this is what is my experience from 30 years in the field. And these seem to be two separate worlds that they often don't come together, and that's why it's very difficult for academics to develop curricula that they can actually bring new knowledge and train workers able to implement them in the field, what they have learned later. At the same time, we have to face certain issues, such as the late development of academic courses, at least in Greek universities, the lack of trained staff, the lack of appropriate training material, and the fact that, as I mentioned before, most of the treatment facilities were quite isolated from what was happening in academia. So the initial steps for training professionals in the field were only in service. For instance, in the drug-free treatment organizations, there was a big program of 12 weeks for in-service training in order to bridge the gap between being an undergraduate in psychology or social work and then coming in treatment to work as a therapist. There was a big gap there. Then we had the opportunity to develop a very good program with the University of California, San Diego, and Nick Mellus is here. He's one of the people who represents the program, with David Teitz, Thomas McClellan, Lisa Nadjavis, on addiction counseling competencies. And this program started running in the end of 90s and is still on. And there are about, I think already maybe 1,000 people who went through this training, and this was very important. And then for the first time, we introduced a certification based on the American certification model of ICUDDR, International Consortium of Reciprocity Consortium. But the thing is that this certificate is very significant and people get jobs in other countries, but it doesn't mean much for Greece, because you need some permission from the state, which this certificate does not actually allow for. The other step was, with the help of Griffith Edwards, to develop, and this is how we met in ICETS, to develop a peer-reviewed journal, which is the only journal in Greece that is peer-reviewed, is member of the Scopus group. You can actually submit papers of a quality standard, and you can read some real good research, and a specialized library on the addictions. But this all was happening within one organization. The organization is still in operation, Kethia. I don't know for how much longer. I no longer work there. But everything was happening, as I said before, in service, in-house. So the universities were not there. Now, the last few years, and only I think because some of the people who worked in this field actually moved to the university sector, some new courses have developed, mainly in the postgraduate level. So we have now 5 university postgraduate courses in Greece. One of them is no longer operating simply because the person retired and there was no one else to take on this job. So there are currently 4 are running. 2 of them are in the department, in 2 departments of psychology. 3 of them are in departments of social work, and 2 of them are in the Department of Education, where I come from, and 1 in the University of Patras, where we actually teach school-based drug prevention and lifelong learning and drug use prevention, and all this material. These are undergraduate courses. This is very important in Greece because in undergraduate courses, these are electives, so students actually choose to follow them. For instance, I have every year at least 130 students following the course, even though it's elective. But it's also important because undergraduate courses in Greece are free in public universities. So students don't have to pay any fees. So this is an important place where you can introduce the classes. At the postgraduate level, you have to pay some fees, not extremely expensive, but still is not for everybody. Within these initiatives, what we started to do together with the Department of Penal Law in the University of Aristotle here in Thessaloniki, KETHIA, which is the organization I was working for, and the Department of Law in the University of Cyprus, was a master degree course running now from 2016 up to date on penal law and addictions. Why we focused in this aspect? Because drug users are not necessarily imprisoned because of their drug use in Greece, but they are in prison for other activities relevant to drug use. So like stealing, robbery, or trafficking, or selling drugs. And therefore, if you look at the Greek prison population, at least 50% of it is people who are actually drug users and have other offenses as well. So we thought it's very important to include the Faculty of Law, to sensitize lawyers who work with this population to learn more about this population and the justice and the criminal justice system. And so we have admissions from schools of psychology, social work, sociology, anthropology, and education, but also a large number of lawyers who, some of them already work in the field and they want to know more about it. Of course, there is a procedure here, more or less I suspect you do the same in your universities. And up to now, we had more than 1,000 applications, and about 500 have already completed with a research thesis, because this is a core element of the course. The course is 18 months, and as I said, there is a research thesis. The first semester is joint for all participants. The second semester, they can either go to the criminal law and addictions direction, or to the legal and therapeutic management of addictions direction, and the third is the research thesis. And more or less, I told you about the aims of the course. But what we are finding as important course elements, and as the previous speaker mentioned, quality in education is very significant. There is a system in Greece, I suspect is all over in Europe, of actually going through a process from the Ministry of Education through which you have to get a permission for your master's degree, and you get a grade, the maximum grade being 10, as for the quality of the education provided, and the same in Cyprus. And we think that we managed to do that recently, and it's because the course has some interesting elements. First of all, it brings together different cultures and from different countries, but also from different organizational perspectives. So we have 2 universities, one in Greece, one in Cyprus. We have one organization working directly with drug users in treatment. Then we have complementary and different disciplines, that is law and social sciences. The teaching is always joined in every class. Therefore we try to go through this multidisciplinary approach, and we also have medical professions who teach all the aspects of harm reduction, substitution treatment, etc. So it's not only psychological treatments, but also other types of treatments. And the theory meets research and practice, because we give the opportunity to the students to receive practice in organizational settings in the second semester, either in substitution programs, in harm reduction programs, or in drug-free treatment facilities. And they are evaluated. This is part of a course, is something they have to do. And then, of course, the research is very important. And having said that, nonetheless, there are some structural barriers. And for me, if we want to do something really important in training, we have to always bear in mind the structural barriers and how we can change them. First of all, at least in Greece, and I suspect it's all over the world because all the years that I've been in the field and I've traveled in several conferences, the drugs field is a rather small field. So you keep meeting the same people all over and over again, and this is very nice because you build relationships, but on the other hand, you also need more people and new people to come in. So there is a small number of staff working in the field anyways, at least in Greece, is less than 2,000, including all harm reduction, drug-free treatment, and prevention programs. And these are very small numbers. Second, there is a lack of new staff recruitments. So the government policies, especially the last few years, do not allow to employ new staff. So mainly staff is there with short-term contracts, and that's not very good because you cannot build a therapeutic relationship on a short-term contract, and if you're worried about your job, then this is more so, and it's very difficult. Then there is a lack of undergraduate program, of courses in undergraduate programs. As I said, there are now 5 in the 20 Greek universities with the different departments, and this is a problem related to the fact that there are very few professors in Greece who actually know this field. I suspect there are less than 10. I can count them. I know all of them. This is a problem. And there is very few opportunities for new staff. If you want new staff in this field, you definitely need to have doctorate degrees, and you definitely need to encourage people to continue in doctorate degrees. I think the last few years, there are 2 that I know of, is not enough. And the other problem is that there is no research funding to actually, Greece is not United States, is not England, is not a big country, is a small country with limited funds, no funding for research. That's a fact. So everything done and all publications are actually done without extra funding. This is good in a sense because you have very clear evidence. You don't have to depend on someone who is paying for your research, but on the other hand, it can be only small-scale research. So that's an issue. And then there is a lack of a professional certification that is actually recognized by the Greek state. So ICNRC is very important, but there are only about 150 people who have this qualification who are already working in organizations. And we did a lot of work trying to recognize this in the state level. It was not possible up to now. Now, for some future prospects, as I said, I would like to see at some point in all schools of education, social work, social sciences, medicine, law, a course, even an elective course that people can take. As I said, in Greece, undergraduate education in public universities is free, so it's a great opportunity that people can actually hear about it, become more sensitive about the issue, especially teachers working with small kids that they live in hard environments. Sometimes they experience very difficult situations. They are the people that we might see later in drug use or in treatment. We could actually stop it there if we sensitize enough the teachers. I think this is very important. Then we definitely need multidisciplinary courses and to bring together different perspectives. we have to offer the whole spectrum of treatment, from harm reduction to full recovery for people who want to do that. I think this is very important. And we need to employ, of course, people with lived experience, and also use practice in the field and experiential learning, action research to understand what goes on in the communities. And link the programs with doctoral research is very important in a 10 years plan to have, when I retire and other people retire, somebody has to continue doing this job. I think this is very important. And we have to do that. We're not still there yet. There's a lot of work to be done. And then you already mentioned that, and I completely agree with you, the need for an international program. It can be an MA, an MSc, or maybe joint international doctorates. That would be great, and perhaps even easier, because sometimes with MAs you have a lot of university bureaucracy making your life very difficult. And I think that could help to co-create a very good program, a positive change, exchange experiences internationally. We all face more or less the same problems, and maybe have some funding opportunities for our students. Thank you very much for your time.
Thank you very much, Anna. And because of the fact that we have all speakers very disciplined, it means that we have enough time for discussion. So that is perfect, and thanks so much to all of you. So, and we are open to discuss, to your questions, comments. Sebastian.
So my name is Bob Bolster, and I've been involved in developing addiction training programs for a long, long time, and have always been kind of, and I've appreciated the fact that Professor Miofsky and his group have been really a long time interested in studying the process of, you know, knowledge dissemination and addiction studies. It's a very interesting field, and there's something very unique about our field in that in doing the research and that you're doing is that, I mean, a big part of the research is how are we doing? And the only way to me that we could really answer that is compared to what? And I've never really understood what the comparator is to, you know, university programs or postgraduate programs, the programs that we do in addiction studies. I mean, it's easy to think about comparing psychology and psychiatry programs or criminal justice programs or disciplinary programs, but we're fundamentally a program, I guess you could say, about a disease or about a social problem. So this would be like, I don't know, training programs in cancer, or maybe it's occurred to me that something like violence prevention would be more of a comparable to addiction, since it's such a complicated social problem. And I know there are developments, like at my university, there is a specialization in cancer now that they've developed. But my question to the panel is, what if you had to think about comparator groups, you know, to answer the question, how are we doing? How is our, you know, our leadership in the world and the organizations that are supporting our work, et cetera, how are we doing compared to HIV? How are we doing compared to what?
Maybe I'll start, but you can definitely help me with that. Thank you for that question. I think it's really important. And we tried to raise this topic a bit. Our colleague, who's also mentioned in the list of prepared publication, we tried to make comparison study of the master's programs in not only in Europe. Actually, we have different regions also in there. The master's, it's not. You're right. It's not possible to compare it 100%. It's most like describing what is similar, what is different, and but still I'm really into this issue. I like, the research in education. That's mine, and I'm really looking forward to finding some program who could be, for example, comparable to our study program in Prague, as we have the addiction specialization as the healthcare program. The graduates are healthcare workers. It's settled in the law, so we have to define profession in between other medical and non-medical professionals. And if you have just a bit feeling that your program could be similar, we can definitely get more in deep and prepare just one-to-one comparison study, and it's related really closely to what Elizabeth presented about quality standards and core competencies. I guess this is the way how we can find the core competencies in our program.
Yeah, I think it's more about finding the inspiration, the missing pieces, and to create something that is comprehensive. Maybe that's more than comparing. Maybe comparing isn't the best word, and I have more thoughts than answers for you now. But it's an interesting question. Yeah, maybe we don't want to compare it. We just want to find something that can give a whole picture.
More reactions? Maybe I can just add, we burn a lot of time trying to create typology of programs, and I'm not sure if we were really successful, because it opens more questions than we had answers with this typology. But yes, we have some first typology of addiction programs, and we are able to sort different kind of programs, but it's just beginning, because the diversity is so huge that it's incredible. I see no other field where diversity is such extensive like in our field. Yeah. Yeah, maybe.
But just adding, thank you for mentioning that, but the typology should be hopefully also published and be a part of this data from the survey. And we tried to compare those 99 universities of ICUDDR members to the typology, and try to reflect how is it real, or if it's just our some idea of how it could work. And there are some gaps and some challenges to be improved. So I'm happy about that.
I mean, I understand what you're saying, and I understand that it's kind of hard to conceptualize what exactly compare. I mean, I'm not interested in comparing Charles University to Virginia Commonwealth. I'm interested in comparing how we're doing broadly in addiction studies versus, say, food security. I mean, these are major international problems, and there's organizations that are out there working on them. I mean, if you had to go by how the world is doing, on addiction, we're not doing so great, realistically. I mean, so, infant mortality has been dropping. A lot of, international problems have been correcting themselves. I'm not an expert on this, and I don't know the data, but my sense of things is that we can't declare a victory, in the addiction field. So I think we need to think about these other, not addiction related or even necessarily health, but fields where there are complicated social problems, where there are international agencies and international programs and things that are out there to try to fix them, and how have they approached exactly the same problems that we're trying to approach, and that you folks are studying, which is so great.
Richard Pates, or lady first. Sorry, Richard.
Sorry, Richard, I can't see you, but sorry. I'm Liliana Ignatova, professor at Medical Faculty in Skopje, North Macedonia. Thank you for all presenters. I'm very glad that I'm here with you today. Related the question before, I was thinking addictology is neuroscience. Psychiatry is neuroscience, neurology is neuroscience, and I can say nobody, but even professionals didn't see it as neuroscience. Probably it can be compared with other neuroscience discipline at medicine, and maybe with something what is not health, outside the health. But when we are talking about medical science, it's good to be compared with other neuroscience discipline. I want to ask you, I heard that in Greece you have a lot of programs, but not in medical faculty. And in Czech Republic you have graduate and undergraduate in medical faculty. I want to ask if you have module or curriculum related to prison health in this in your. You talk about legal departments, but do you have something in a curriculum related to public health? Because prison health, because prison health has a lot of specific which are in line with drug addiction.
No, maybe I was not clear. There is a master degree in addictology in the Department of Medicine at the University of Athens, where I come from. And I'm not sure if there is somebody teaching at the undergraduate level. We don't see it in Greece as in prisoners as part of the public health issue. But we see it as either in penal law and addictions or in this department of addictology. They look at this issue as well. Okay, so it depends. That's why I think there are cultural variations that need to be taken into consideration. This is important.
Yeah, it's very important. Yeah. Prison health is public health.
I'm not saying no, I agree with you. I'm just saying that I don't know if there is a degree on that, okay, specifically for prisoners.
Maybe I can just add, yes, it's part of our curricula, and we have a specific training for students for working inside of prisons and before and after. And by the way, we have a quite interesting success that it's 4 or 5 years ago when General Direction of Prisons created specific positions for people graduating from our program, and we have 16 people now graduates working in prison. And there is necessary to have this qualification for applying for these positions, and they are leading counseling services in prisons and specialized units for people with SUD inside of prison. It means that it was big shift. Don't worry, but on the other hand, this is big success, but we have still many troubles and communication troubles with prisons. That's always very tricky how to deal with it, but on the other hand, yes, we penetrated the system, and yes, people graduate from our program are working inside of prisons.
There is a lot of differences in context. Like Anna said, we have lack of staff, and we have 2,000 staff in addiction field, and we are saying we have lack of staff. That's why I'm a lot interested about curriculum in medical psychology faculty, but we are lack of staff, 4 psychiatrists and 1 social worker, 5. It's lack of staff. In Greece, 2,000 is lack of staff. If we are 2,000, I will be much more than happy.
I just wanted to add that thank you for that question. As I mentioned before, like the criminal justice and law issues in prisons is really underestimated issue, and it really depends on the program you provide. If it's just a short-term course for, I don't know, 8 hours, or if, because we have bachelor, master, and PhD programs, so we can, you know, we are free in adding this specific topic into the course and continue from the undergraduate to graduate level also. And if you would be interested, I could send you the papers we published, because there was differentiated also the specific programs, the degree programs oriented specifically on criminal justice issues and working in prisons. So I would
Also,
love to
we have a part of prisons in our quality standards, and we are creating clinical guidelines for addiction work in prisons right now. And I was working there for 3 years for a part-time job, so if you have any question, just ask.
Thank you, Elizabeth. Professor Tsiboukli.
Thank you very much. It may be that what I'm about to say has already been said, but it's, I mean, Bob's point was really interesting, because the reality is that addiction comes from so many different disciplines. You know, it is medicine, it is psychology, it is sociology, it is the law, it is pharmacology, and therefore trying to integrate all of those is not easy. And the second point is there is no universal political view of addiction. If you look at the international way that people handle the problems of addiction, you know, I can go back to the 1920s in Britain, where they recommended, the Rolleston report recommended substitute prescribing for opiate addiction. That's still not necessarily common throughout the world, and it's just a massive change of things. And also in my lifetime in addiction, I started at the beginning of the AIDS epidemic, and the things that we've seen change since then in terms of the whole concept of harm reduction, which wasn't really there before then, and all the things associated with that. So I think I love what you're doing, but you're working in a very difficult environment because there are so many different influences and impacts on that.
Can I add something to what Richard just said? Just to agree with Richard that there are different policies across the world, but within the same country also there is a variation in policy within the 30 years. So you can see many changes happening, and that creates problems also for treatment, but also for program development, for training development. And the perception of a person who uses drugs can vary from being somebody completely stigmatized to being somebody with a mental health issue, right? So there's a big change, and that creates many, many issues. So still there is a discussion that has to be done in the field, in the scientific field, and if we're going to agree what are actually the roots of drug addiction, and then that might help us to build better programs.
And also, that was the result of our attempt to prepare the core competencies and quality standards. That was the result. That it's not possible to do it easily, and we get back really to excuse me, to the roots of the definitions. That's what you mentioned, both of you. It's really important to differentiate if we are talking from the European perspective, with having, I don't know, like how long is it? Like 2005, we have our addiction studies in Prague, and in comparison to, I don't know, African concept, or we discuss with Asian colleagues, and there is not possible to do harm reduction. So it's how to prepare the core curriculum, the real basics, when we can't stand on the same, same ground in all aspects. But still, it led us to the idea that we need to go deeper, go even like to the real base of what creates our field from all the perspectives you mentioned, not only healthcare, but also like social perspective, cultural, psychological, and neuro everything. So it is really important, like to to make it easier, just be so clear that it could be accepted in the whole world, and then we can add extras, like regionally specific competencies or something like that, we can achieve in our political and cultural systems. It's really important. Thank you.
Thank you, and we have a space for another question, comment. Richard, you would like? Yep.
I don't want to hog the conversation, but I think the other thing that we need to remember, and it's reflected in things people have said, is that sometimes substance use is functional. And I can remember when I first started, I went up to Merseyside, I spoke to a guy who was very poor, lousy housing, no job, and I said, what's the problem with heroin? He said, a problem, it's a solution. And that, you know, for so many people is there, and that's the reality, that unless you actually solve these problems of housing and jobs and everything else, you're not going to solve those problems. So, you know, it's as hard as we do to provide good prevention programs, I've always thought in my years of working with drug users and alcohol users that for so many people, it's functional for them.
Thank you for this point. Thank you. More questions? Comments?
Can I make a final comment to what Richard just said? That we definitely need to take into account the socio-cultural circumstances. And as they change, they co-create. I'm not saying it's the only factor, but they co-create the circumstances for drug use. And this is very, very important. Unless we include this in the curricula, I don't think we prepare well enough the people to work in treatment. Thank you.
Thank you, Anna. So, thanks so much to all of you for your contributions. Thank you for your time and interest being here, and please enjoy the rest of your time here in Greece and today evening, and see you tomorrow on our following program. Thanks so much. Have a nice evening.